thank you very much, and thank you to Maria and to Robert for all your help with organising this series of lectures. And as I say, I'm David Williams. I'm a stroke physician in Beaumont, and I hope you won't need to meet me on a professional basis in terms of stroke. And I hope that today I'll leave this very interactive and just give an overview of stroke and some of the interesting developments in the stroke field over the last number of years. So you're probably aware that yesterday was actually International Stroke Day. So we're only a day out, and it was excellent timing for the talk this evening. 1 in 6 of us are at a chance of having a stroke. And these are people who've suffered a recent stroke in the past. You might be familiar with Michael Lynagh, who's the Australian rugby player who suffered a tear in one of his arteries in his neck and caused him to have a stroke. Hillary Clinton suffered a stroke recently, a kind of an unusual type of stroke called a sinus venous thrombosis. And Andrew Marr, you may be aware of his programme. He again suffered a stroke as a result of vigorous exercise when he was on a rowing machine and tore one of his arteries when he extended his neck. And caused a stroke, and he's making an excellent recovery. You may have seen him recently on the television. He did a programme on Angela Merkel. So, and again, testimony that stroke whilst it is a devastating illness, people are able to make full recoveries from their stroke. So in terms of Ireland, it's probably the third leading cause of disability, of death and disability worldwide. But in Ireland, about 10,000 patients suffer a stroke annually and are admitted to hospital with a diagnosis of stroke. And perhaps even more importantly, there's 30,000 patients who are survivors of stroke. And these patients have significant residual disability, including weakness called hemiparesis, an inability to walk. They need help with the activities of daily living, common tasks that everyone has to do during their everyday routine. They also suffer from clinical depression and cognitive impairment or problems with memory and learning. So it's a significant cause of disability. So what we want to do and try to do is to try and prevent the stroke happening in the first place. And if we look at our population demographics, you can see what's happening in terms of Irish demographics. Our ageing population are getting older, so that means that there's going to be a large increase in the older age groups where stroke is quite prevalent. So whilst the incidence of stroke in each of the age groups is falling because we're better at managing prevention strategies for stroke, the numbers of patients who will present to our hospitals as a result of an increase in ageing population will increase. So we need to be ready for that challenge. If you look at the causes of death worldwide and how significant stroke is, it's approximately responsible for 10% of deaths worldwide, which is a significant number in terms of the overall causes of death, and quite important. So what is a stroke? Stroke occurs when the blood supply to the brain is interrupted in a vital part of the area, if it's blocked or reduced. So there's and it tends to happen abruptly. Without a proper flow of blood, part of the brain is then deprived of oxygen. The nerve cells in the affected area of the brain can't function and become damaged. And often this damage is irreversible. In terms of ischemic stroke, and I'll discuss the major types of stroke, we lose about 2 million brain cells for every minute that we don't treat a stroke. That puts things in perspective. Now, we're able to compensate, and the brain has fantastic ability to compensate the effects of a stroke. But if you think about it, 2 million brain cells that we lose every minute a stroke is untreated. It heightens the importance of rapid assessment of patients with stroke. And one of my, I suppose, if there was any message that I'd like to get over from this evening's talk, is that time is brain. And if there is a patient who suffers a potential stroke, they need to seek medical attention as soon as possible. And what's a TIA? Well, a TIA is a kind of I like to use TIA and stroke very similarly, because a TIA is what we often used to call a mini stroke. It occurs when a blood clot blocks an artery for a short period of time. The only difference between a stroke and a TIA is the duration of the symptoms. The blockage tends to be transient. However, that blockage can still be enough, even if it is transient, to cause damage. And we know that when we do brain scans in patients who have what we call a mini stroke, if we look at the brain scan, that will show or that will demonstrate that the patient has already had damage to the brain and has had an infarct or stroke. In TIAs or mini strokes, that transient or temporary. Again, though, we should be thinking about TIAs or mini strokes as an emergency, because patients who suffer a major stroke, if you go and ask them, did they suffer symptoms of a mini stroke before they had their major stroke, they'll often recall an instance when they may have suffered symptoms of a mini stroke beforehand. So it's a bit like patients who suffer from a threatened heart attack, as we often call it. This is a threatened stroke, a TIA, and should be treated with the same urgency as a patient who may be suffering a stroke. So we talk about stroke in terms of there's two major forms of stroke. One is called an ischemic stroke, when you have impairment of blood supply to a particular part of the brain, often caused by a blood clot. And here's just a picture of how this might happen to demonstrate it. You've got a major blood vessel which is supplying blood to an important part of the brain, the left hemisphere here. And you can see that if there's a clot in the blood vessel, it goes up into the brain and causes an obstruction and reduces the blood supply to that area of the brain. So if that is a part of the brain that's involved in speech, patient's speech may be affected. If that's a part of the brain that's responsible for moving your right arm, again, that part of the brain will lead to weakness in the right arm or the right leg. So depending on the part of the brain that's responsible for the particular function, if that's affected by a blood clot, you will get a disability as a result of that. The other type of brain of stroke is called a brain hemorrhage or a hemorrhagic stroke. And these tend to occur, they're less common, and they're caused by a bleed from one of the main blood vessels supplying the brain. So these are small little blood vessels that often are weakened over time. And one of the biggest causes of this weakness is prolonged high blood pressure. So patients who have high blood pressure over a long period of time, if it's not well treated, it's a pure pressure effect. Can cause weakness in the blood vessel and cause blood to leak out and cause a brain hemorrhage. So that's the less common cause of stroke. So the signs and symptoms of stroke, and I'll refer mainly to ischemic stroke because it's the more common types of stroke. But again, patients who suffer from a hemorrhagic stroke will often present with similar type of symptoms. And you're probably aware of the FAST campaign. So patients who suffer a stroke, they get weakness in their face, they may get weakness in their arm, they get weakness they get problems with their speech. They're not able to get the words out that they want to get out, or if the speech is slurred. And I suppose the other issue and the most important thing about the FAST campaign is that you need to seek medical attention urgently. And that's the main message of stroke. So I'm going to bring you to the website of the Irish Heart Foundation, and you have probably seen this video numerous occasions. This was a video that was sponsored by the Irish Heart Foundation, which is a charitable organisation, and unfortunately we haven't been able to get the funds to continue this campaign. But this is the campaign that was, and hopefully it's going to work.
When a stroke strikes, the damage spreads like a fire in the brain. To spot the signs of a stroke, you have to think and act fast. F. Face. Has the face fallen on one side? Can they smile? A. Arms. Can they raise both arms and keep them there? S. Speech. Is their speech slurred? T. Time. Just like a fire, it's time to call 999 if you see any single one of these signs. The faster you act, the more of the person you save. When stroke strikes, act fast.
So that patient or that person has suffered what we call a mini stroke because they've resolved, their symptoms have resolved over the period of the video. But again, the key message is the time part of the FAST campaign, to seek attention, to seek medical attention urgently. And that's one of the issues that we have, because this picture of the patient up on the left has suffered a cardiac arrest and suffered from chest pain. And if you suffer from chest pain or any pain, you're going to go and seek medical attention quite quickly. And we'd all do that. It's human nature. However, if you suffer from some slurred speech or a weakness in a hand or a bit of numbness in the arm, well, you might just put it off for the next day, or you may even forget about it. And the worry is that people won't take these concerns seriously and seek medical attention. So there's probably very poor symptom recognition among the public in terms of stroke and how it can present, and a lack of awareness about the urgency and the various treatment options that are available. Because one of the key things about ischemic stroke is that if you get treated if you present within 4.5 hours to a hospital in Ireland with symptoms of stroke, you can receive clot-busting treatment to try and improve the symptoms and signs of stroke. So that's why it's a very tight time window. 4.5 hours is the figure to keep in your mind. And the earlier you present and get the treatment, the better the outcome. Now, there are a number of stroke mimics, and that often makes it very difficult for us as doctors sometimes to clarify if the patient has had a stroke. So sometimes migraine, which often presents with a headache, or you can have migraine without headaches, can sometimes present as stroke. Sometimes patients can present who have a seizure, and again, that can present as a stroke. People who collapse for whatever reason, it can mimic some of the signs of stroke. If you've got problems with your middle ear, if you've got balance problems, that can sometimes present as a stroke. Again, if you have problems with neuropathy or nerve root problems, if you have problems with your eyes, if you're a diabetic and you have very low blood sugars, that can also present as stroke as well. And sometimes, very unfortunate, some patients who have brain tumours can sometimes present with a stroke-like syndrome. So there are a number of other things that can sometimes present as stroke, but I suppose it's when people are seen by the doctors, it's often quite apparent that the patient is suffering from a stroke. The key thing about stroke is that it tends to happen abruptly, and recovery tends to happen in the next few hours with treatment. So there are a number of campaigns available which try to improve our awareness of stroke. If you go to the NHS in the UK where I worked, we had the FAST campaign there. Again, that's where the Irish programme developed, and you probably see that the FAST campaign now is on all of our ambulance as they go by. I like the Hip Hop stroke program, which is a program that was set up in America amongst school children to educate school children about the signs of stroke, because we've had a number of cases where it's actually been the grandchildren who've alerted the medical services that their grandparents were suffering from a stroke and sought medical attention, or their parents were suffering from stroke and again sought medical attention. So it's all around public knowledge and that everyone knows the signs and symptoms of stroke and can seek medical attention early. My colleagues Anne Hickey and Lisa Mellon in RCSI did a survey of the FAST campaign to see how effective it was, and we looked at admissions to Beaumont Hospital and Connolly Hospital to see if the FAST campaign actually made a difference in terms of people presenting to our hospitals with stroke-like symptoms. And we found an up to 60% increase in presentations under 3 hours during the actual campaign. So it had a huge effect on bringing the appropriate patients to hospital for treatment. And again, that 3-hour window is important, because then we could offer these patients acute treatment which would improve their outcome. Unfortunately, what happened when the campaign was stopped, the number of presentations to our hospitals fell down as a result. So these type of campaigns need to be sustained. and we need to, I suppose, we need to lobby our politicians and to give us money to try and get this public health campaign in the public perspective. So, again, I'm going to refer to the most commonest type of stroke called an ischemic stroke. And this is diagrammatically what happens to a blood vessel in the brain. We have a clot that goes up and it causes an occlusion to one of the major arteries supplying oxygen to the brain. And that causes infarction, or the tissue in the brain dies. But there's an area around that area of dead tissue that can be saved if we reperfuse the artery. Now, how do we do that? We can do that medically by delivering a drug called TPA, or thrombolysis. So that's an injection that's given in through the vein, and then the drug makes it all its way up to the brain and tries to break up this blood clot. Again, the earlier that drug can be administered, the greater the chance of recovery and the greater the chance that we can save this area of infarction. So that's one way of trying to improve blood flow. There is another way, which I'll hopefully be able to demonstrate now, that we've been able to do in Beaumont over the last number of years. So this is a representation of a clot getting into the major blood vessel in the brain. And what the radiologists do is they go up through your groin and up into the blood vessel up here. And this is called a stent retriever. And it essentially goes through the clot and you deploy this kind of mesh. And hopefully, and quite successfully, we've been able to do this in a number of patients. And we remove the clot. It's not without complications. We don't use it for all our patients, but in selected cases, this has been quite successful. And literally, patients who went in to have this procedure, they had a weakness on the right side, for example, and after this procedure, they were able to walk out and had made a full recovery. And that is probably some of the opportunities that we do have for the management for stroke. And it's an exciting development that we can offer patients. And here's a real-life example. This is a clot that was removed from one of our patients. You can see it's up to nearly 2 centimeters long, and that was lodged in one of the major vessels in the brain and causing an obstruction. And when it was removed, the patient made a full recovery. Now, the other way of trying to, as I said, to try to get to remove that clot would be through a drug which we can give through the veins, and hopefully that tries to dissolve it. But again, the most key thing that we found with all our patients who make a good recovery is if they present early, they've got a better chance of making a full recovery from from stroke. And we talk about this chain of survival where there's rapid detection and early warnings where we detect patients in the community. They're blue lighted into the emergency department. So there's rapid paramedic and pre-hospital care. Rapid transport, and the hospital is made aware that the patient is coming in with a suspected stroke, so the stroke team are already at the door, ready to bring the patient to CT scan to have their brain scan done. It's important to do a brain scan first before you can offer any treatment, because if the patient has had the other type of stroke called a hemorrhage, we're not going to obviously give them clot busting treatment, and it's a different management. And again, we can offer them, and then after this, we offer them either patient needs rehabilitation, or perhaps in some cases they need surgery. So this is how it's meant to work. We have, and again, the key time, 4.5 hours. The patient suffers a stroke, ring 999, goes to the ambulance service, and the ambulance brings them into hospital. They see their doctor, they're assessed by the doctor, they have their CT scan. The CT scan is read by the radiologist, and then we either give them TPA, which is the clot busting treatment, or in some cases we may be able to remove the clot using the stent as I showed earlier. And hopefully the patient has made a good recovery as a result. And that's what we hope. Now, what's the future? Again, we talked about stent retrievers, which go up and remove the clot from the affected artery. This is what they're doing in Germany, where the actual CT scanner goes out to the patient and the stroke team go out to the patient in an ambulance, and there's actually a CT scanner in the back of the ambulance. Only the Germans could do this, and it's fantastic. But it's another way of getting the team to the patient rapidly. And again, it's important that we can do this. So the patient goes, the ambulance turns up at the patient's home. The patient has a CT scan. If they're suitable, there's no contraindication to the clot busting treatment. They get treatment with the medication. Now, in Ireland, one of the other challenges that we've had is certainly, and particularly around rural areas, is access to care, because we would like to be able to offer this service to everyone in the country. But unfortunately, it's not always available. So if somebody is in the west of Ireland, quite remote from a hospital, how are we going to be able to give those treatment for their stroke? So there's been a recent development called TRASNA, which is the Irish National Telemedicine Service. So this allows a patient to go to a hospital that may not have a dedicated stroke team. And the patient, but what can happen is that the patient can have a CT brain scan, and the doctor can look after them and can phone or have a tele-link with a stroke centre, and can discuss whether this patient needs to be given clot-busting treatment. So the patient can then receive treatment over a telemedicine link, and the patient can get treated and make good recovery. So that's the future. We hope that this is from the national programme is going to be rolled out very soon, and this will hopefully allow more access to clot-busting treatment for patients with stroke. And you may be aware there's been a number of clinical programs rolled out over the last number of years, and stroke has been one of them. And one of the important things about the National Stroke Programme was that it gave us the opportunity to set up stroke units around the country. And this is the number of stroke units that have developed over these years. And a stroke unit is very important for the patient. It's a bit like a coronary care unit, where patients with stroke are all managed in the same environment. You've got expertise in medical care, expertise in nursing care, expertise in rehabilitation. So all those important services that they're looking after the patient. And as I say, we've got a lot in most of the large hospitals in the country. They all have stroke units now and can develop and can deliver 24/7 thrombolysis for patients. But again, there may be challenges if you're in a peripheral area or a rural area and you want to get to your nearest stroke centre. You know, it may be difficult. So that's the challenges we face in Ireland to allow access to stroke care. So, I suppose ideally, you won't need to see a stroke physician, and we want to try and address risk factors for stroke to try and prevent the development of stroke. So what are the major risk factors for developing stroke? Well, there's some lifestyle issues, and I suppose the usual reliables will always say that smoking is bad for you, but certainly smoking is quite toxic and increases your risk of stroke. It causes accelerated atherosclerosis or narrowing of the major blood vessels, including those blood vessels that supply blood to the brain. So smoking is a big risk factor. A diet high in salt or high in cholesterol is not good either, and again, it needs to be addressed. There are medical risk factors, and I'll discuss some of those this evening. It's such as high blood pressure. High blood pressure can be quite important in the development of the hemorrhagic stroke or the bleeding in the brain. But it can also be associated with the other type of stroke, the more common stroke called ischemic stroke. And I suppose one of the issues around blood pressure is that as we get older, our likelihood of developing blood pressure increases. So most patients over the age of 70 are likely to have raised blood pressure. And it's important, you won't know that you've have high blood pressure unless you actually attend a doctor and have your blood pressure taken, or now a local pharmacy that will also be able to take your blood pressure. Cholesterol is also associated with stroke, particularly ischemic strokes. The high cholesterol increases your risk of stroke. And another important cardiac condition called atrial fibrillation, or an irregularity in the heart rate, is a strong risk factor for developing stroke. It increases as we get older, the incidence of atrial fibrillation, and again, it's often silent. We don't know that we have it unless we've been examined and seen by a doctor or nurse. Atrial fibrillation is an irregularity in the heart rate. If the heart becomes irregular, little clots can form in the heart, and those clots can go off from the heart into the brain to cause a stroke. And then there are non-modifiable risk factors, which is something unfortunately we can't do anything about, such as age or gender and genetics, which can in rare cases be associated with the development of stroke. So smoking is, as you know, it's a big no-no. It increases our risk of cardiovascular disease, but certainly is a significant risk for developing stroke and increased atherosclerosis. And we know that even if you have been a long-term smoker, that if you stop smoking, you can reverse some of the harmful effects of smoking. So it's never too late to stop smoking, would be my motto. An unhealthy diet increases your risk of developing conditions such as high blood pressure and also diabetes. And diabetes itself is a risk factor for developing stroke. And overweight links in very well with an unhealthy diet. It increases our risk of high blood pressure. It increases our risk of hypercholesterolemia, and generally increases our cardiovascular and risk of stroke. Lack of exercise, again, an important risk, because if you don't exercise, we tend to increase our weight. If we don't exercise, it tends to make the bad cholesterol, called the LDL cholesterol, rise. If we exercise, we can actually improve or increase the good cholesterol, called the HDL cholesterol. So again, exercise is very important. Although some people who've suffered from excessive exercise, who may have suffered stroke, may not say that, because obviously there's a risk of excessive exercise. And I talk briefly later about this condition called cervical artery dissection, which is often associated with excessive exercises and which can sometimes cause stroke. Excess alcohol intake is never good, I suppose, but obviously in moderation, like anything, because we know that red wine can sometimes have a beneficial effect on cardiovascular disease, but obviously to avoid in excess. And anxiety and stress, there aren't a number of studies on them, but anecdotally we do know that excessive stress can increase the risk of cardiovascular risk, particularly can increase blood pressure at times, and certainly relaxation techniques can help reduce stress levels and reduce risk of cardiovascular and stroke. Are there any other risk factors that we should discuss? Well, cholesterol, and I mentioned cholesterol as a risk factor from a poor diet, but certainly what happens when patients or in individuals with high cholesterol, what can happen is that the cholesterol can build up in the walls of the artery. Now, smoking also does this. Smoking causes this build-up of plaque in the artery. And what can happen is that this plaque or fatty deposit can rupture, and a small blood clot can form, and this blood clot then can travel to the brain and cause a stroke. So cholesterol, if you can reduce your cholesterol, what happens is you reduce these fatty deposits and plaque, and you can make the blood vessel nice and smooth. And certainly medications called statins, you're probably aware of those, that reduce cholesterol, can help to smooth out the blood vessel wall. and protect the blood vessel against developing these plaques and blood clot. And again, if you stop smoking, again, you can get remodeling of the blood vessel, and again can improve the smoothness of the blood vessel so that the blood flows freely through the blood vessel. Blood pressure. Well, this is important for both types of stroke. So high blood pressure is known as hypertension. It means that the blood pressure is increased in your arteries. High blood pressure, the figure to remember is 140/90. So if the top figure is known as the systolic blood pressure, it's the pressure that happens that occurs when the blood is pumped out from the heart. The bottom number is the diastolic blood pressure, and it's the pressure when the heart rests between various beats. But the key thing is to remember the figure 140/90. You want to have your blood pressure less than that, or even lower. And it's important to know what your blood pressure reading is. And the reason why we don't, and we can't do that now, by visiting our pharmacy or by visiting our general practitioner to get our blood pressure taken. And you probably remember these three important people. This was Yalta, and they all suffered a type of stroke called a hemorrhagic stroke, a bleed into the brain, as a result of poorly controlled blood pressure. Churchill, Roosevelt's, and Stalin. And Stalin's blood pressure, Roosevelt's blood pressure was over 200. The top figure was over 200, and I think at the time his physician was concerned about treating it because he was afraid that it might have impact his decision-making process during the conference. But again, it illustrates that blood pressure has been with us for quite a long time. In those days, they didn't have the same number of medications that we now have available to effectively treat patients' blood pressure. This is an unusual cause, and you may have heard of this. It's called a patent foramen ovale, which is a hole in the heart, and there's debate in the medical literature at the moment on whether a hole in the heart actually predisposes us to having stroke. Certainly in people who have what we call cryptogenic stroke, or stroke that we don't know the cause of, it seems to be more prevalent. But we're not really sure how to treat this. The idea is that when we've got the hole in the heart, blood may traverse. Small little blood clots can go from what we call the right side of the heart over through the hole into the left side of the circulation, and the left side of the circulation provides blood supply to the brain. 1 in 4 of us in this room will have that hole in the heart still, because it doesn't close over from birth. So it's quite common, and it's very difficult to know if it is really associated with stroke. But there is a lot of debate around this particular subject. And in some centres, people have this hole in the heart reversed and treated surgically. This is the one we need to be aware of, and again, it can be very. People often don't know they have it, and particularly as we get older, we don't test our pulse. But this is atrial fibrillation, and again, if you can see this, what happens is the heart is fibrillating and not pumping very effectively. What happens is a small little clot forms in the chamber of the heart. It goes out through the major part of the heart that's pumped out, and that clot then can go to the brain and cause an injury. Now, I think there are various campaigns that advocate taking your own pulse, and it is something that you can do and just time it over a minute and take your pulse. And if it seems to be racing, and these are the kind of the warnings that you should think about seeking medical advice. If your pulse seems to be racing sometime or most of the time when you're feeling unwell, if your pulse seems to be slow most of the time when you're feeling unwell, if your pulse feels irregular, and that's the one that we're really worried about sometimes, if it's jumping around, even if you don't feel unwell. Now, sometimes a lot of caffeine can make your pulse feel quite irregular, and you need to be careful about caffeine intake. And if your persistent heart rate is above 120 beats per minute, so you can take your pulse, you can measure it over a 60-second period and work out what the heart rate is. Or if it's below 40, you seek medical attention. Once it's detected, the treatment is quite effective, and the treatment is usually a blood thinner known as warfarin, or there are newer agents that are now available that can thin the blood. And by thinning the blood, what you do is you prevent the development of these small little clots in the heart and prevent the stroke occurring. This is the unusual cause that I mentioned about, and this was what often happens in people who are exercising or quite rigorously. If you extend your neck quite acutely, there's a risk that you may tear the artery. And by tearing the artery, what happens is this causes a reaction in the blood vessel to form a blood clot. And this blood clot can then go up and cause a stroke. And that's what happened in the instance of Andrew Marr when he was on a rowing machine. He was doing a vigorous exercise. He extended his neck, caused pain in his neck, and he developed a stroke shortly after as a result of a dissection. Medications following stroke are very important because most patients with stroke will be prescribed medications, and these help to reduce the risk of having a further stroke, and it's important that these medications are taken regularly. So these medications can range from blood thinners such as aspirin or clopidogrel or warfarin, cholesterol-lowering medications. Patients who have diabetes may need to take their diabetic medications, and blood pressure tablets often need to be taken following a stroke. And all of these medications together reduce significantly the risk of having a further stroke. So after having a stroke, what we want to do is prevent the next stroke happening. Diet is important, and again, we recommend a healthy diet, a balanced diet, and patients with stroke could sometimes suffer from constipation, so a good healthy diet is important, and to drink plenty of fluids to avoid dehydration. Recovery from stroke is important. I know my colleague Francis Hogan gave a MiniMed lecture a number of years ago on rehabilitation. I won't deal in that in a huge part of this lecture, but again, to emphasise that rehabilitation is very important in terms of the rehabilitation of the patient with stroke. And it varies from person to person. Some patients can recover spontaneously. Rehabilitation with physiotherapy, occupational therapy, with speech and language therapy, that again accelerates the process of regaining functional ability. And each individual's rehabilitation program will vary, so everyone is different in terms of the improvements from stroke. And this is a picture of the stroke rehabilitation team, and again, these are based in most of the stroke units around Ireland, and these are all essential people in terms of the stroke rehabilitation pathway for the patient. So what do we expect from rehabilitation? Well, it's important that goals are set and the patients can meet these goals. Practice is important as well with family members, because unfortunately we don't have the resource to provide rehabilitation over a 24-hour period. So sometimes it's very important, particularly when the patient goes home, that they practice their rehabilitation skills and at home. And family are very important in encouraging patients with stroke in their rehabilitation. When patients come in and they've suffered a stroke, they get allocated times for their therapies. The location can be in either the physiotherapy department or the speech and language department or the occupational therapy department. So what are the problems that patients with stroke, even if they haven't made an instantaneous recovery, suffer from? Well, they suffer from communication difficulties, physical difficulties, problems with memory and how they perceive the world, and behavioural and emotional difficulties after stroke. We often see patients, if the part of the brain that's affected affects the swallow, that can lead to problems with swallowing after stroke. One of the common causes or features of stroke is patients' speech being affected, and it's often the biggest fear of a stroke is that your speech will be affected and you won't be able to communicate with the world. So the message in it comes in, and the patient can't get the message out and can't speak and communicate with the world, and that can be quite a challenge in terms of rehabilitation. And we can have problems with actually forming words, where the patient is said to be what we call dysarthric. They're unable to form the appropriate words, and they often speak with a slurred accent. So there are a number of supports that we can offer, or the rehabilitation services can offer, in terms of supporting communication. So that, and I'm constantly amazed by the ways that people can communicate with the world after having a severe stroke. And there are physical difficulties that you're probably aware of when people suffer weakness. They have problems with their balance, coordination and sensation. And all of these are addressed by our physiotherapists and our occupational therapists who help with regaining function after stroke. People often suffer from continence issues. They have problems with visual difficulties, and probably one of the most underestimated difficulties that patients suffer from after a stroke is this enormous fatigue that they suffer, and that can be a significant problem in patients who suffered a stroke. Cognition is important because patients have difficulty with attention or concentration. They have problems with their memory. They have problems with planning and solving particular problems, perceiving their own environment, and they have a reduced self-awareness. Again, depending on the part of the brain that's affected, people can have apraxia, or difficulty with knowing what they want to do, and they're unable to do it. So this patient down below has problems dressing, and that can sometimes be a significant difficulty associated with stroke, where people can't put the clothes on in the right order, and making a cup of tea can be quite a challenge to patients with stroke. So that's where our therapy sessions come in and try and improve the outcome for the patient. And this is what we're always aiming for the patient who comes into our stroke unit, is discharge home. And this is, from day one, we're aiming to get the patient home, to be rehabilitated, and to be looked after by their, to be either independent or be looked after by their family. There are some patients that we don't succeed in getting home and need to be looked after in an extended care facility. There are important support services that are available in the community to help patients with stroke, including public health nurses, the community therapists, a day hospital, the day centres and respite care, and the voluntary organisations that can offer care and support to our patients with stroke. And this is just some additional information on the web, where you can get more information about stroke. I'm sorry I haven't been able to be as comprehensive as I'd like to, but it's a very short lecture this evening. I've hopefully given you an overview of stroke. So I'd like to thank you again for your time, and I'm happy to take any questions. Thank you very much. Thank you. The take-home message will be to act fast in a situation where you have a suspected stroke, and to seek urgent medical attention, because you can lose up to 2 million brain cells for every minute that a stroke is left untreated.